Hello, welcome to another episode of the world famous Podiatry Detectives with myself, Sherlock, and the new gleaming, he's got a nice new background, Colombo. Hello, Colombo, how are you?
I'm okay, thank you. How are you, Sherlock?
I'm great. I am great. How, let me educate our listeners and viewers. How have the first few days of fasting been?
Um, First few days haven't been too bad. I generally like the first half of the Ramadan. Where I tend to struggle is toward the last 10 days of Ramadan, when my energy level has like slowly depleted downwards. Um, but if I stay sensible and eat healthy and eat the right stuff, then it's not too bad.
Just anybody that's listening or watching and wondering what we are talking about, we both adhere to the Muslim faith, and that means that during this month of Ramadan, we do not eat or drink for 16, 17 hours. So we eat at 4 o'clock in the morning, and then we eat at 8:30 in the evening. It's my favorite time of the year, and I'm sure it's Atosi's favorite time of the year too.
Absolutely.
And it's an amazingly spiritually enlightening time of the year. So we are going to be talking about ankle sprains today, and it is going to be an awesome presentation. It's going to go through so much information, and we've got videos and we've got slides and we've got a lot of information. But before we start that, Mr. Tosif, time to put you on the spot. Now, I've been wondering for the last few days what to ask him. I thought, let me be kind to him this week, and then next week I'm going to be really horrible to him. So actually the next episode rather. So everybody that knows you knows that you love cricket. You are a cricket mad. If you could sleep with a bat and a ball in bed, you would sleep with a bat and ball in bed. Tell me who your favorite current batsman and current bowler, any kind of bowler, any kind of batsman, anywhere in the world. Who are your two most famous?
I'm gonna sound biased. I must say that Babar Azam, he's Pakistani captain and a batsman. He is my current favourite batsman. And in terms of all-time great, Shane Warne. But you said current. That takes me to Yasir Shah. He's a really good leg spinner. And I think Afghanistan's Rashid Khan is a really, really good leg spinner. So yeah, at the moment, they're two of my favourite players.
Yes. We learned something new about the elusive Mr. Tosif. Okay, shall we start? 1 second. By the way, I am not a cricket nut, but if I had to pick a batsman, it would be Ben Stokes, just because I like his energy. And I really don't know about bowlers. I like Jeffrey Archer, but I like a couple of the Australian quicks as well. Okay, so we're going to be talking about ankle sprains with a focus on rehabilitation. This, when I was composing this, I spoke to Tosif, and this could literally last for hours and hours and hours because it's such a vast topic. And then he told me off, and he goes, sort yourself out. You need to keep it a bit more concise. So we've tried to keep it as concise as possible, but there is a lot of information to cover. Now,
one of the things, Abid, we've been doing this for a little while. I think this is our 4th or 5th episode.
Yeah.
Yeah. And one of the feedback which we did get from some of my colleagues and friends, and they said that they are really long to be able to keep track on and watch them and stuff like that. And I said, it is really, really, really difficult to keep them short, because if you start to basically cover even each topic, you can go on for like a whole day.
We haven't, I mean, Tosif, you would agree, we haven't even gone deep into each topic. We've purposely, and so as Tosif, purposely tried to dial ourselves back with each one. Anyway, let's get to the presentation for ankle sprains. This is generally, on the left-hand side, you'll see something that's quite acute. So that's just happened in a day or so. And then on the right-hand side of the screen, that's been going on for about a week or so.
100%.
Generally speaking, you will get, I'm going to go through the mechanism of injury in a minute, but you'll get a lot of swelling on the outside of your ankle, pain, swelling, bruising. They can't put their foot down properly. It's horrible. Would you agree, Tosif?
Definitely.
Yeah.
Definitely.
Now, this is an interesting statistic. So in 2005, they did a study and they said 25,000 sprained ankles every day around the world. That's 15 years ago. I think you could times that by 2 or 3. I think there's easily in the region of 50 to 70,000 ankle sprains around the world, especially when there's a lockdown and everybody's running.
I was going to say that possibly even doubled in the lockdown, because everybody I know, they're running around doing the exercises, doing this, that, and everything. So yeah.
The interesting thing about this study, which was done by Mango et al., it was 30% of people who just used rest and ice alone still had pain after 1 year, which goes to show you the importance of appropriate rehabilitation. Would you agree, Tosif?
Yeah, and I think I can easily say that 70% of my ankle sprains that I see in my clinical settings, they've had it for like 3, 6, or 12 months, and they're still having symptoms, and that's when they come to see us. Only 30% of the acute sort of ankle sprains that I tend to see in the clinic.
Okay, so I'm going to briefly go through the structures now. There's a lot of information here. On the right-hand side of the screen, you'll see a classical mechanism of injury. So it's usually on the outside of the ankle. Okay, so it's very, very rare to get to actually try sprain your ankle on the inside in the other manner. The most commonly affected structure is the anterior talar fibular ligament, the ATFL. But as you can see from the left-hand side, you can damage the peroneals. You can damage, there's a calcaneofibular ligament. There's a lot of other ligaments. A couple of things I want to really point out here is you can, from an ankle sprain, where you can see the fifth metatarsal bone on the left-hand side of the screen, you can get a fracture to that. It's called a avulsion fracture. So the peroneus brevis is attached there. If you really sprain your ankle badly, you could get damage to that bone. The peroneus brevis can come away a little bit, and you'll get a small fragment of bone that's loose within there.
I would actually demonstrate that on the thingy. It's just right here.
That's right, exactly.
The base of that's the base of the fifth metatarsal, and that's where you generally tend to get avulsion fracture.
I'm going to go over some of the other structures on the inside, but would you agree that the ATFL and the peroneals are probably the most commonly affected? Yeah,
absolutely.
Okay. Now, hold on. You can damage the structures on the inside of your ankle too. Absolutely. I had a patient recently who had a very nasty. She had a very nasty ankle sprain. And she had almost exactly that X-ray where you can see there, where there's a little bit of the tibia, which is the bone on the inside, came away. And I was wondering why she's not healing very well. She had to go into a boot for a couple of weeks, and the rehab is very, very slow. So that can happen. And it's what also we have is
this sort of so the inner side of the ankle sprain is predominantly what I've seen in the clinic is associated with a certain activity. For example, if sporting activity, or if they're running and they've basically misstepped, they're running on the trails and they've misstepped it, and that's when it's very common. Otherwise, the deltoid ligaments, which are the ligaments supporting the inside of the foot, they're really strong, aren't they?
True. This particular patient of mine, she was just crossing the road. She wasn't doing anything. And I think she had previous ankle instability, which is why previous injury, if you're not treated properly and rehab it properly, if it happens again and it really gives way, she damaged the inside and the outside. She damaged the deltoid ligament, which, as Tosif said, is an amazingly powerful fan-shaped structure, and it has various attachments, and it is strong. You don't damage it very often. But she damaged that, and she got an avulsion fracture. So there was a lot going on. She's not the typical patient. It's not what you just said, Atosif, is the typical patient. It's generally on the outside from running or trail walking or hiking, playing football, something like that. So do we need an X-ray? Ottawa rules.
Mhm.
The Ottawa rules state.
While you explain about that, what I'll do is I'll kind of do a little bit of a demonstration. So in terms of the palpation that we're actually doing is that behind the lateral malleolus, there are, you can do like behind the medial malleolus and the base of fifth metatarsal, as well as navicular sort of bones. And these are the general sort of sore points. If you tend to find that these are sore points, as well as patients can't walk for more 4 steps at home or in emergency departments, that's when you start to basically think, right, we need an X-ray.
Absolutely. Absolutely. Everything what Tosif said is completely true. If you're managing this at home and you don't know where any of those bones are, don't worry about it. If you can't walk 4 steps, go and get an X-ray. Simple as, all right? If you can't do at least 4 steps. Now, I love this slide. I love it so much. You know why? Because like within physiotherapy and medicine generally, people love acronyms. So when I first qualified, it was how do we manage a injury? And we use the acronym PRICE. So that was P standing for.
When I initially I used the term RICE, then it went to RICE, then it went to police, and I was peace and love. I love the last one, peace and love.
Yeah, absolutely. So yeah, I forgot to mention there is a precursor to Price, which was Rice, and so each of these letters stand for a different modality of treatment. So protect was the P, rest, ice, compression, and elevate. And then police was optimal loading, but peace and love, baby, peace and love. It's moved on a lot, and this is now, I mean, hopefully I'm going to finish my MSc in sports and exercise medicine, and the amount of external lecturers that come in that talk about peace and love is crazy. The main thing here, the couple of main things were, they've said to avoid anti-inflammatories. They've talked about educating the patient, which I agree. They've talked about...
So in terms of, when you talk about anti-inflammatories, we're talking about cocodamals, ibuprofen, and stuff.
So this is what I was going to talk to you about. Let me just finish this off, and then I'm going to talk to you about this. So they talked about optimism, like we need to make the patient feel better about it, so they heal. And there is some evidence regarding this. Actually, there's a load of evidence regarding that. Vascularization, keeping fit, doing some other activities so you can get blood flow going within the ankle so it heals. Completely agree. Now, I have an issue regarding not using ice and not using ibuprofen, because I think there is a place for it in the initial stages, and I am reticent to say there is not. What about you, Tosif?
Well, I agree with you. I think ice plays an important role when it comes to, we think about swelling, but ice for me plays an important role in terms of pain reduction. And that's really important. And similar to anti-inflammatories, the main purpose is the pain reduction and the swelling. So, and inflammation basically. But I would be happy to use paracetamol.
I mean, paracetamol is one thing, but they're talking about anti-inflammatories. I mean, I agree with compression and I agree with everything. Load is, I mean, we're going to talk about this anyway, but we do need to load the ankle early. If you ever watch, I mean, we can't watch it now because we've got the COVID-19 bloody pandemic, but when we watched a Premiership football game, if somebody injured themselves, you would see them on the sidelines with an ice bag on their ankle or their knee. Now, trust me when I say, because I have met many of these Premiership doctors because they've given us lectures, these are the best doctors and physios anywhere in the world. I kid you not. They are, and if they're still using ice, there must be a reason for it. But this is how the management of ankle sprains has evolved. Now, out of all of those things, I would say the most important thing is you don't want to just elevate it and rest it and not do anything. You want to try to load it. So try and put weight on it, even in a controlled manner, as early as possible. What would you say to that?
Yeah, absolutely. And I think as we're going to go through more the treatment and rehabilitation processes, we can kind of, a lot of the time when I see patients, and the reason they don't want to load it is because A, that it hurts, B, that they're worried about like making it worse. But if you actually educate them about how to load, what's the safe sort of loads to work with, and manage the pain along with it, I think it definitely makes sense, and that's the way to go as well.
Absolutely, absolutely. Okay, so I love Stephen Covey's quote. This guy's a author, entrepreneur, many different things. Now, so rehabilitation, where do you start or where do you want to finish? Now, I'm gonna read his quote out. To begin with, the end in mind means to start with a clear understanding of your destination. It means to know where you're going so that you better understand where you are now. So the steps you take are always in the right direction. Now, this can count for many things in life generally, a lot of different things in life. But when it comes to rehab, if we are rehabbing a recreational runner, or a marathon runner, or a footballer, or a rugby player, or a hockey player, or a cricket player, because you love cricket, or a slightly elderly person that likes to go on walks on some like cobblestones, we know where that destination is. We know where we want to get to. That really affects what we are going to put in place. I'm sure you're going to agree with me on that. I'm sure.
Yeah, my rehab plan is geared toward what patients want the outcome needs to be. So there's no point rehabilitating somebody who is only going to be walking around, and an elderly patient and expecting that they'll be able to do running around the block and stuff. So it has to be very specific, and I think it becomes, the initial stages perhaps are similar to everybody, but as you get into the later stages of the rehab, it is important to have that specific rehab for specific outcomes. So for a runner, it might be a little bit different to a football player, to a cricketer, or to somebody who is doing long jump and stuff like that.
That's right. So I'm gonna talk about this in detail. Some of it I'm gonna skip over. I'm gonna go over it briefly, but I will talk about how to specifically rehab different kinds of people. Now, this is an interesting way to look at rehabilitation. The way that I think about rehab is when on the left-hand side, you can see you've got an injury. So tissue, you really want to focus on tissue at this stage. You want to control pain. And then we slowly start moving through these stages to build up capacity, energy release. Then we start to move towards movement drills, running, training, competition. There's a journey. Now, not, as you just said very correctly, not everybody needs to go on this journey. Some people can stop about halfway through, about like 4 hours in. They don't need to go on these. Others need to go further up. As I see, that's my phone ringing, but let it ring. Let me just switch it off 1 sec. This is the technical things that happen. Okay, I'm back. I'm actually closed, so I'm not seeing any patients. This is my office, obviously, so I hope they don't ring back again. If they do, I'm just going to leave it off the dial altogether. So this basically tells you the paradigm that we work within, and it's adapted from Lancaster's paper from 2009. Do you think this is a good way of looking at?
Absolutely. I think it's a very systematic way of looking at it, and I think it's really important to kind of explain this to the patient, and saying that this is the journey we're going to actually go on very periodically, because a lot of these elite sort of players who want optimal performance, they want to get there tomorrow, don't they?
Yes, and what I haven't mentioned within these slides is the importance of an MDT team. Now, you spoke about this when you spoke about where you work. Remind me again.
Movement therapy clinic.
Movement therapy, sorry, it's my old age is catching up with me. Movement therapy clinic, but involving an MDT team for a elite athlete is vital. Although me and Tosif can do a lot of the role of a physiotherapist, but it's always good to get the input of physiotherapy colleagues, especially those that specialize in rehabilitation. So we moved, I mean, that's the overview. I'm going to talk about specifics now. This is looking at more specific things that we may do during this. And what you may notice here is I'm also thinking about fitness. So if you can't, what we don't want to do is affect their cardiovascular fitness. So we've got to find an activity that they can do that they're not weight bearing heavily. That could be sitting on one of those arm bikes, could be doing swimming that's not putting, like with swimming, we got to find a stroke that's not going to be putting too much pressure on the ankle. So we have to experiment with that.
I've seen so many recreational people who do like sports, running, other recreation, that they get like one injury and then they just completely stop.
Yeah.
They just completely stop and don't do anything at all. And when they come to see you and they're saying that, oh, okay, I don't do anything because my ankle hurt. I said, what about your arms? What about the upper body? Can you go to the gym? Can you do knee exercises, hip exercises without actually moving the ankle too much? And they think, oh, okay, I never thought of that. And it is really important, isn't it?
Yeah, I mean, they can do open chain exercises where they're not putting weight on their feet. It is very, very important, but not all. I mean, this slide specifically is for running in a straight line, linear running. But it's not everybody needs to go on this whole journey. But if we are rehabbing a runner, we need to move beyond just the initial rehab that we are going to talk about, and we need to start thinking about incorporating different runs on different surfaces, because a runner that's running on a trail run will have different demands on their ankle compared to someone who's running on the pavement, for example, or on the grass. Completely different demands placed on structures. Now, this is an interesting paper from Mania et al. 2018. It talks about ground reaction forces. So that's the amount of force going up through your body when you are doing a movement. Now, in a rugby player, you can imagine it is not the soleus, which takes a lot of the strain initially, which is the muscle deep down in your calf muscle, takes a lot of the strain. But you can see how everything else is involved.
Yep.
So I mean, we've got the gastric knee, we've got the hamstrings, we've got the glutes, different glutes, the glute med, the glute max, and the adductors. When me and Tosif are rehabbing athletes and patients that are involved in multi-directional sports, like rugby or cricket, not cricket is very, very linear, but rugby, football, hockey, then we need to think about a lot more than just that ankle joint. There's so much more we need to think about, which we're going to start.
Just to educate you about cricket, Abid, the cricket isn't linear.
It is linear.
When it comes to like bowling fast, it's not linear when it comes to like bowling spin ball. It's not linear when you are fielding.
Okay, I'll give you one thing. When you're fielding, you can have change of directions. Now, when you're bowling, When you're bowling, it's not there's a change of direction. You've got more like torsional. So this is you are right. So there's a different kind of shearing forces being placed, but it doesn't. It's different to suddenly having to change direction. But that
definitely is different to. But when you are fielding, you can, because the ball doesn't really come to you nice and straight. It jumps up. It just moves to the left. It moves to the right. So you have to kind of change direction.
Steve has for cricket, yeah. Okay, I will concede that cricket we should also be thinking about a holistic view for cricket. I completely concede. Okay, so let's talk a little bit about the types of rehabilitation. Now, Alfredson program in 1998, these are the heel drops, or any eccentric program. You can do it for patellar tendonitis as well, where you're stretching, aren't you? You're basically elongating it. That was one of the first ones that really took on eccentric training. Then Silbernagel in 2007, he did one for Achilles and patellar tendonitis, and it was a mixture. It was a mixture of concentric, eccentric, so that's up and down movements, and plyometric. I am a big fan of Consgrad, 2009, 2010 papers. It was heavy, slow resistance. I'm a big fan of that.
So for me, I use Alfredson in initial stages when patients are finding it like things are painful, and lengthening of the Achilles is generally quite well tolerated as compared to the concentric movement. But yeah, I definitely agree. Heavy slow resistance is my go-to.
It's for me it's the daddy, because if you can make them stronger, that'll prevent this happening again. I will put an asterisk here, because I would say in the initial stages, rather than eccentric, I am doing isometric. So that means I'm getting.
Yeah, I mix it up with the isometric. It all very much depends on what patients can tolerate. So that's where I would look at. If a patient cannot tolerate eccentric, then I would go with isometric. By the way, an isometric movement is when you are loading the structure, but you're not actually moving the structure. So eccentric loading is when you are lengthening the structure. So when you're doing the heel drop, your Achilles lengthened. And eccentric and concentric is when you lengthen and shorten. So that's the difference. So you can stand at the edge of the stairs and just bend, get your heel drop down a little bit, and then you can just hold. So you are loading Achilles tendon there, but you're not moving it.
For the ankle sprain, I tend not to do my eccentric in that way. I'm doing it in I want to get them into a certain movement, which is like get them into inversion or eversion, and trying to get them to, and we'll talk about that a bit later. On the right hand side, you'll see the different types of rehab programs for tendinopathy. Now, most of this we've already been through regarding the reducing pain, building from functional strength and power. What number 5 there, which is developing short stretch shortening cycles, is basically it's that introducing that like plyometrics, so hopping, different types of hopping and different multi-directional off different kinds of surfaces, off a higher surface, off a lower surface, maybe using sand, maybe using a foam cushion, many different types. We want to develop that that kind of that ability that it can stretch and shorten rapidly, that rapid movement, so it can maintain a structural integrity during an activity. Is there anything that I've missed out, Joseph?
It's a good way of assessing and seeing where patient is at, and when we have no pain, people think that, right, I can go running, I can do this, I can do that, but doing plyometrics can actually tell them whether they are ready to do what they can actually do and what they can't do. So I use that as an assessment. If somebody tries to say to me that, Joseph, I want to go do this, I want to go do that, I get them to do my plyometrics, and that's when they tend to feel the difference that I'm not ready yet.
not quite yet. That's what the government keeps telling us about the lockdown, isn't it? Not quite yet. Okay, so Bob Marley, if you don't start somewhere, you're not going to go nowhere. So we need to start somewhere. There's nobody just talking
Any
about
Bob Marley songs?
it. I'll do it later. I'll do it for
So,
you. Are you going to sing for us, Asif? I've been trying to sing an Ed Sheeran song for ages. All right, so 4 stages of rehab. Peace and love, baby. So,
well, if you
peace
give
and
peace
love.
and love to anything, if you give peace and love to anything, it gets better, doesn't it?
That is true. That is true. So, using the previous acronym where we talked about the different things that for peace, protection, elevation, so on and so forth. But the aim is to reduce swelling and restore tissue homeostasis. Basically, meaning we want to get the tissues to get the correct blood flow going through it, and to reduce the amount of water and everything else that's going on within those tissues. Now, I'm going to try and play this. It's not letting me play. Okay. So, just for you to see if we made videos. So, before I'm going to play it, but I'm going to let me make it mute. So, this is 1 to 3 days after your ankle sprain, and it's very important that you know what your aim is. At this stage, I am not trying to build strength. I am, as we said before, we're trying to reduce pain and reduce, and we are trying to start to appropriately load it at this stage too. So if I just move this video on a bit, you will see I'm just literally with my funky socks, right? I'm moving. I'm just moving my foot left and right, and I'm doing mini circles. And the idea is just to get some movement going within the ankle joint. And then after that,
looking at your ankle, I think you have reduced mobility. Why don't you make an appointment with the podiatry clinic?
I can't find a good one. All right, so I'm just gonna go back a little bit there. So what I showed there was grabbing a towel, putting around the ball of your foot, and stretching. At this stage, you're going to be stretching your calf primarily, but you're also going to be stretching your entire ankle mortise and your complex also. Then, as you'll see when I'm going back, I'm putting the towel on the floor, trying to pick the towel up. I'm trying to move it, just trying to get some movement within the ankle. And then what you'll see later on is I'm just shifting my weight while you're sitting down. Just shift your weight towards the injured ankle. So in this case, it's on my right ankle, and I'm just shifting it that way. So I'm appropriately loading it. I'm not asking too much. If you can, then you can just briefly get up for a second and put weight on it. If that's too much, just this much movement in the first 3 days might be enough. Now, not everybody needs to go to do this prescriptively. Some people can start walking in day 2, but others can't. Is there anything you would like that you do differently to what I've just showed there in the first 3 days?
I looked at it says ball of foot pain like our last video.
Yeah, that's right. Is there anything?
So I think you've basically mentioned all the exercises that I would do. The main aim is, as you mentioned there, reduce pain, restore tissue homeostasis, and what you're doing is that you're kind of moving the ankle inverting, everting. You can try writing A, B, C with it, and that's one good way to kind of mobilize your. So mobility is the main issue here. We're not building strength. We're not building any miraculous sort of ability in your ankle in first few days. All you're trying to do is just keep the mobility going.
Absolutely. Okay, so let's move on to stage 2. Now, I'll just pause this. Now, hold on. I'm back on. Okay. Now, this is day 4 to day 10. Here, the aim is we want to start improving strength. We want to initiate some proprioception neuromuscular input. Sounds very complicated. It's not. It's essentially meaning I just want to get some balance going. All right. So by this stage, the swelling should be really coming down because you've done that peace and love or rice, please, all of that. You've done all that, and the swelling is going down quite a bit. But it may still be swollen. So I'm gonna mute this again. Now, what you'll see me here is I've got a long green TheraBand here, and I've got it around my foot, and I put my foot down all the way, and I'm holding it, and then I'm pushing it out. So I would do it in two different motions. I would do it with the foot completely down and the foot completely up, because you're working different ligaments when you do it.
That's right.
And I would do 15 reps, 3 sets.
Mm-hmm.
I'm going to show you again where I'm doing it that way. Before I show any more, would you agree with that? Would you agree with that particular, at day 4 we start to use a TheraBand?
Yeah, and again, I'm very much a believer of, I don't know whether you've seen these things or not, where how much pain during an exercise is acceptable. Yeah. So like 0 to 4 is acceptable, 4 to 7 is when you get an indication that you need to change something. That can be either frequency, that can be reduce the numbers that you are doing, the strength of the TheraBand. Lots of things can actually come into, which can basically mean that, right, you need to reduce that a little bit or keep it there. And then if it's 7+, that tells you not to carry on with that exercise because it's too painful, and not to carry on with that exercise. So I tend to get my patients to follow that paradigm, and that's how they progress.
Absolutely, completely agree with you. It's the VAS scale. I do normally say, tell me how you're feeling the next morning. If it's on 0 to 3, that's an acceptable. If it's 4, maybe we need to dial it back. And you are right, there are different colors TheraBands, and the different colors tell you how much, how dense it is. I'm going to move this video on a little bit more. So this exercise works on the structures on the inside. This actually works on your tibialis posterior, but it also works on other structures because we do need to also focus on the structures on the inside, because it may be that you never had enough strength on the structures on the inside, which is why you compensated on the outside. So we need to take that holistic view. Would you agree?
Yeah, totally.
Okay, so what we're doing here now is I am now introducing some single leg standing. Now, when you've had an ankle sprain, you can't even do this for about 3 or 4 seconds because it's that painful. Yeah. This is where you have to start building this up. So we let me just play this on, and I'm just trying to like stand. If you can get up to 30-40 seconds, you're doing great, absolutely great. But what we find is generally they can't get it up that long. They can't stand on their 1 foot for that long. One of the other things I'm showing you here is a single leg heel raise. Also very good. It builds up strength in your calf muscle, but it also helps the structures in your ankle also, and builds up some strength. Also, I mean,
sorry, now to add a couple of things here, that when you damage your ligaments, one of the things which gets affected is proprioception, the ability for you to kind of understand where in the position that you are in terms of your ankle. What happens is that people who have it as a long-term or hasn't been seen, and one of the papers that you actually quoted, that after a year, they still have pain. And I think it's because of their inability to strengthen but develop that proprioceptive sort of control, which leads to that discomfort, pain, and it keeps happening again and again, and that's very important. So where it's important to build strength, proprioception exercises are key in terms of developing proprioception as well.
Absolutely. So what you'll see here is me doing, now this is a general calf stretch, but instead of holding the stretch, what I'm trying to do is I am doing some mobilization. I'm moving in different directions. And this gets that joint capsule moving in different directions, which is what we need to do. What I've also going to show here is this may be closer to day 10, where I'm getting them to walk on their tiptoes down in the front room, or then walk on their heels. You wouldn't do this at day 4. So what I'm showing you there is a progression from day 4 to day 10, the kind of exercises you would do. Let's move on to stage 3. Now, here, I want to get away from that kind of TheraBand. I want to get that kind of TheraBand working. I want to get more into weight bearing exercises. So I'm trying to build some real functional strength and get some progressive load going here. So what you'll see here is taking me from day 4. Oh, that was me. Could you hear that audio then? So okay, there you go. So I'm on a foam pad there, which makes my proprioception very hard, because it's a lot more harder to maintain on an uneven surface. Now, if I can get them on a beach or somewhere on sand, it's even great. From there, I've moved on to a foam cushion, which I find it's even harder. It gives you have to really work on the proprioception. Just doing that and standing without doing any exercises is quite hard. I'm going to show you where we can add in a start excursion exercise while you're doing that, but it becomes harder and harder. That's a wobble ball.
In order to kind of mention and progress really safely, they need to be ready for the next stage, because if you go onto wobble board straight away thinking that you're going to strengthen the ankle, you can make matters worse, can't you?
Absolutely. There's got to be an exit criteria for each stage. Generally speaking, that's why it's so important to come and see me and Tosif. We need to assess you to make sure you are fine to go to the next stage. Although we are showing you a rehab program here, each stage has got certain markers. Now, what I'm showing you here is the start excursion exercise, where you stand on one leg, you reach out, and you're trying to aim for 12 o'clock, 1 o'clock, and move across. Now, initially, put your foot down, but if you're really good, you can just keep your foot in the air. And obviously, I'm doing 9 o'clock and moving across. That's actually quite difficult.
I don't think you're really good.
Even though I demonstrate it almost every day, I'm not brilliant. You can see my knee going in, so you can see that I've got weak glutes there. But yeah, it's not great, but
once again, I'm going to give you a number for the podiatry clinic: 0121 285 5656.
Check you advertising your clinic. All right, I'm not going to be like him and advertise my clinic. So go to those. All right, he's better than me anyway. All right, so look, I'm doing the foam cushion start excursion exercise there. So you can do that same start excursion exercise on the foam cushion. Now, what I'm showing you here is what runners should do. I like them doing the swing straight across and across their body. I learned this from James Dunn, actually, which is who's an awesome running coach. But I do think that running across the body is great. And I briefly talk about orthotics here. Now, orthotics, I think, have a place at stage 3, and I like to have wedging put on the outside of the orthotic, and that helps to take the strain off the structures of the outside and gives you that window of opportunity. There's another exercise that I forgot to talk about. So this is another kind of TheraBand, which is a short TheraBand, and you put it around your foot, you get onto the balls of your feet, and you're moving across. Okay, so you're really putting stress on it. It's if you've got swelling in your ankle, you're not going to be able to do that at all. Right, so this is one of the criteria. It has to be that you have pain-free range of motion at this stage. So these exercises may be closer to day 16. You may start off with just standing on your foot at day 11 on a foam pad, but when you start moving towards a wobble board or this kind of exercise or start excursion, you're looking at day 18 to 21, something like that. Have I missed anything out, Tosif?
No.
Okay, great. Stage 4. Okay, we are now really thinking about getting some strength and developing that like a reactive stretch shortening cycle. And let me go through it. So I have got there in my hand a ball. And what you should do is either I want you to stand on one foot again, either get a partner to throw the ball at you, you're trying to catch it, and maintain your balance. Also, just throw the ball against a wall, try and catch it, as you'll see me doing there, and I catch it. So that's really forcing you to put a lot of strain on that foot, and that reactive strength, right? So you don't know how that ball's going to bounce. You have no idea. You have to react quickly. That's what you want to build up within the ankle joint. You can do that on a foam cushion if you are really brave. This is day 21 plus. This is prevention goes in here, and just juggling it, because forcing your eyes and your brains to do something else, while you're standing on one foot can become very hard. Now, I've got a medicine ball here. You can do this with a dumbbell or a kettlebell, but you should, actually, I've got it in the wrong hand. Move it across, Abid. I'm talking to myself. Thank you. Move it across, move it across. Okay, now it's in the right hand. So you need to do a single leg Romanian deadlift, but it's you basically you want to put the actual weight down and back up again to get some strength going in that ankle joint. I'm going to move that forward, and now we're talking about getting a stepper. So we want to get some like reactive strength where you're quickly going up, quickly going down, also building up some reactive strength. Similarly, I want you to jump down. Now, this is a controlled height. This is not a really high height. It's not a box jump where I'm getting you to jump on one foot. So that you want to move that on, but very quickly. When we go into the latter stages, hopping. Yeah, I look quite good in that t-shirt.
Well,
you know what? Sometimes I ask myself how hot I look. But anyway, so I'm jumping.
I was going to add guarding mechanism. So when we have an injury, we always try to guard the area, don't we?
Yeah.
And I've had several times I had this conversation with the runners and stuff like that, and they would say to me that right, I'm ready to do this and I'm ready to go out. And it's amazing how many times you get them to jump up on the on a step, and then when they're jumping down, there is that definite sort of hesitation, and they're just not ready for it. And you just and it's amazing how when they basically rehab properly and they get to a stage when they are confident, they jump off like that, and then they think, right, I'm ready now. But that little hesitation always gives me a thinking that I need to work more, like they need to work more on that.
Now, not everybody needs to. I completely agree with you. That's why we start off with, we go from control to chaos. This is always my thinking. I want to go from a rehab program where everything's controlled. I've got a step height that's controlled, but then I want to move towards chaos where things are changing and they have to adapt. Not everybody needs to go through stage 4. This stage may be suitable for some people. Not everybody needs it. Like, I wouldn't get an elderly person doing some of these exercises, but runners I would, and footballers and stuff like that. But let me move on because we are coming up to an hour already. Bonus stage of rehab. Okay, yeah. We are talking about sport-specific activity. I was tempted, because I love this. I really love this. I was going to really go to town on it, and I'm thinking, I'm not going to have enough time. This is one of my passions because I see so many elite athletes. Now, this basically goes through what we would do in the acute stage. Some of my athletes have got access to their own private pools. I might get them to do stuff in a private pool. And then I'm trying to get them into some pitch-based, footballers and rugby players, some pitch-based drills, okay? And some, later I would get them into some like slalom running and different kinds of pitch-based drills. Now, this goes into more of a progression for plyometrics. I'm not going to go through these 2 slides. It will take forever, absolutely ever. But what I do want to say, and Tosif would agree with me, is that when we start plyometrics, it's not that we're just going to throw you into plyometrics. You've already mentioned how we're going to progress them through plyometrics. Plyometrics, there are different stages of plyometrics. We'll start off with something slow, eccentric. We'll start doing some squat jumps, depth jumps, box jumps, and we'll get it into real chaos. Would you agree with me?
Yep, definitely.
Brilliant. I'm glad.
All dependent on on the patient and what we will be trying to achieve.
Absolutely. Now, final thoughts. First of all, the first thing there, the road sometimes is not always smooth.
Oh,
Now,
no, running
who was that?
50
Who was
at the
that?
top.
Who was that guy? That was it. Tom Groom. That was it. With that chart. That and he goes. People think it's going to be like that when it's really like that. Yeah, that Tom Groom. Awesome guy. Awesome guy. Sometimes you're going to have ups and downs. It might the actual rehab. Sometimes we might tweak something and we might have to go back a few steps. Sometimes it'll go well. Even with all the best will in the world, and with the two of the best podiatrists in me and Tosif in the entire world, we still may get things wrong, and that's with the best will in the world, because we're not watching you do the exercises 24 when you're doing them, and structures sometimes heal at a different rate.
Everybody's different. Everybody heals at different rate, and compliance. I think compliance with the exercises is a real issue for me. When I'm dealing with the high-end athletes, not a problem. They actually overdo it rather than underdo it, and they're very particular and they're very meticulous. But then when you're dealing with somebody who is just a general patient who had a sprained ankle, and as soon pain disappears, they just don't want to carry on, and they just don't bother with it. And I still think that they need to develop that proprioceptive and the strength and conditioning, even though that they're not actually participating into any running or any other activity. They still need to have enough strength and proprioception ability to be able to do normal day-to-day life activities.
Yep. Tosif, have you ever ultrasounded these?
Well, I have. I've actually had a recent a walker who basically twisted the ankle, and I have ultrasound him a few times at the initial stages, at the acute stages. Absolutely pointless. Perhaps I don't have the strongest machine, the best machine to be able to find that, but again, I don't think it was. It is successful because there's a lot of swelling. You're not going to be able to penetrate through to look at these tiny little structures. More in latter stages, yes, you can identify ATFL, and you can have a look and see whether there is a tear and stuff like that. So yeah, you can do it, but I think you got to be looking at MRIs to have a look at it in real detail.
So I'm going to briefly talk about imaging here. You are right. In the initial stages, I'm not ultrasounding it. If they're an elite footballer or athlete, they may just go for an MRI, or somebody that's somebody that has the means to go for an MRI straight away privately. But in the latter stages, yeah, definitely, I've got better at ultrasounding the ATFL. I used to struggle with it. Ultrasounding the perineals, great, I can do that. Some of the structures are a bit difficult to ultrasound. But
you mentioned doses and stuff like that.
We're going to talk about that. But one of the things I'm looking for in the ultrasound is so I put my ultrasound probe right on top of the ankle, and I'm looking inside the ankle joint. I'm trying to see how much fluid or neovascularization there's there. So one of the things we're looking for is an osteochondral defect, or something. They've done something to the talus. They've done something to the tibia. If there may be a reason to ask for an X-ray or an MRI. Syndesmosis, high ankle sprains. I don't see many of these.
I don't see many, and I think they're very specific to the injury or the mechanism of the injury, aren't they?
Yeah, very. I've yet to see them. I've seen case studies of them, but I have, maybe because I'm not dealing with that particular demographic. It happens a lot more to basketball players and American footballers, and it's a different kind of ankle sprain, and it usually happens from impact. Maybe some rugby players may be getting syndesmosis injuries. Syndesmosis is three structures on the outside of the ankle, further up. That's exactly where he's pointing, just there. Yeah. Orthotics. Now, I touched upon orthotics. You tell me about orthotics.
For me, I think when I'm doing the assessment, and if there is any contributing factors where I feel that this is the reason why they possibly are getting the ankle sprains, then I'll probably address that with an orthotic, or I do a short-term orthotic to basically assist with their recovery.
Completely agree. I will actually get them into an orthotic quite early, just to offload them, a semi-custom orthotic with some wedging on the outside of the orthotic. You have to wear left and right. The other one that you haven't injured won't have the wedging, but you need to have something in the other foot, otherwise you're going to cause discomfort in your hips.
Yeah.
But orthotics are very important. I would put a proviso in here. Sometimes I'll put them in a boot, depending on how bad the swelling is. Injections. Do you use injection therapy for ankle sprains?
Not a lot.
Not a lot. I do. I find that oftentimes there is, so I do injections into the sinus tarsi because I find that they'll get discomfort around there, they'll get sinus tarsi impingement from an ankle sprain, and then I'll do a high volume injection into that sinus tarsi. Please show everybody where the sinus tarsi is, to see if on your foot. Hey, there you go, on that side there. I very rarely I inject the perineals, but I do inject the perineals. I'm not afraid of injecting them because I think I know what I'm doing.
Well, I think the important thing here is that if you've got access to the ultrasound machine and you can do a guided injection, then it's not a problem. Injecting sinus tarsi is not a problem. You can do it blindly with your eyes closed, but
Well, everybody else can. Please don't try it at home on your own. So Steve said you could do it blindly with your eyes closed.
With regards to ligaments and tendons and stuff like that, I always like to do a guided injection.
It is not. It's for ankle sprains. I try and avoid it. This is normally, if I'm injecting, it's been like 18 months, 2 years, and it's not getting better. And then I'm thinking, all right, I need to try.
Yeah, it's more advanced sort of stages when you've tried everything else, but they're just not getting there. That's when I would consider it, but I don't do it a lot.
Now, just to put a proviso in here, a lot of people can function very highly with no anterior talar fibular ligament, which is the most commonly ligament in for an ankle sprain. Many Premiership footballers don't have an ATFL, but we're trying to treat pain here. Not that's the main thing, because if we can get rid of the pain, they can get their function back, and just breaking that pain cycle can be great. Surgery.
Surgery, again, it's very much dependent on what we didn't really talk about there are grading of the sprain. So the early sprains where there's just a bit of stretch, then there's partial tears, and then there are complete tears. And if there are complete tears, then surgery is an option. In some cases, again, it's very specific to the patient. I
think the only time I may send them for surgery is if they've damaged a bone. So if there's bony damage and it's not getting better, we may send them for surgery. I maybe I'm too conservative. Maybe, I don't know. Maybe if we spoke to some of our surgical colleagues, which we have a few of, maybe they would say, just get him in the operating theatre.
Yeah.
All this nonsense. I don't know. I'm not going to say I have a lot of knowledge regarding it. I don't even know what surgery they would do for it. But I think usually it's not required. But I do know of some footballers that have had surgery. Is there any other final thoughts, to see if that anything I've missed out? Because you did quite rightly say that I missed out the grading system. Is there anything else that we should have talked about? No,
I think we covered it quite well in quite a bit of depth. And I think if somebody needs to take one thing from this, and that is that it's a gradual process where you progress gradually with your rehabilitation, and pain reduction does not mean that there is functional and there is power and there is ability there for you to do the activities that you've done previously. So make sure that you do sport-specific exercises and rehabilitation before you get there. Otherwise, the likelihood of this happening again is there.
Absolutely. There's myself and Colombo saying thank you. Before I finish, I want to say, if we are rehabbing you and you are involved in a sport that involves cutting, so that's football, I'm going to mention cricket, rugby, all of those, then we need to start thinking about a pitch-based rehab. So getting into some like slalom runs, into some sub maximal cut runs, and then maximal cut runs, acceleration, deceleration, lateral running. We really want to prevent this from happening again. Let me
just to quickly give you an example, like with regards to the cricket, because I had a fast bowler, as well as I had a gentleman who is a batsman, but he fields at the slips. So when you're fielding at slips, you're like constantly jumping to the right or the left when the ball edges, and it's a sudden sharp movement. And being on the ground, using different techniques to be able to get them to be ready for it is really, really important to prevent the injury happening again. And as you rightly said, it is important that they spend that time. And for me personally, it's that confidence thing as well. When you've done it in practice and you are you feel that you're there, then you're confident enough to be able to perform that in stressful match performance, match situations.
Absolutely. I mean, that's exactly what we've been saying, that we want to take them from control to chaos. And so the way that you rehabbed that guy would have been different to how I would have rehabbed a footballer, because he's first of all in the slip, he's going to be in a semi-squat position waiting for the ball, and then his weight transference is going to be very, very quick depending on which side is going on. So yeah,
to catch the ball, you see, so they're kind of just going into the air to catch the ball. So the power needed to be able to just from a static position. So if you're running and then you're jumping, it's different. The power needed is different because you've got momentum behind you. When you're static in one position and then you generate that sort of power, the power needed is a lot more.
Goes to show the importance of seeing the right person for rehab. Absolutely. Okay, so the next episode, which is going to be on Thursday, is going to be Tosif is leading it.
Yep.
Heel pain. I'm looking forward to you doing this, Tosif. It should be interesting.
I think it's going to be an interesting one as heel pain. It's something which we see pretty much all day, every day as a podiatrist. And I think the aim of the next talk is that I'm going to kind of mention different types of heel pain, but we're going to be focusing toward predominantly plantar fasciopathy and the rehabilitation and what patients can or people can do at home to get themselves better. Great.
I'm looking forward to it. Absolutely looking forward to it. Thank you very much for listening and watching, and we shall speak to you soon.
Great. Take care, everybody.